Thank you for coming to College Research Day. I'm glad to see so many posters out there. It's very exciting to be back in person since before the pandemic. So I just want to say a quick couple thank yous before we get started. In setting up College Research Day, I want to thank Dean Cummings for his support, Karen Tarnas, which none of this would be possible without her, Michelle Strunge, and the whole College Research Committee. We all worked really hard on this to get it back in person and give you guys a good experience. So with that, I'm going to turn it over to Mary Jo, who's going to introduce our keynote speaker.
Great. Good morning, everyone. I'm Mary Jo Pilot. In case you don't know, I'm the program director for the Physician Assistant Studies program. So it is my true pleasure to introduce Dr. King, Andrew King. He's an accomplished clinician researcher who's contributed to the education of hundreds of students here at Wayne State since joining in 2013. I'd like to take a few moments and highlight some of his many accomplishments. Should know that he has over like 30 pages of accomplishments, so I'll try to turn those down here. He's currently serves as the medical director of the Michigan Poison and Drug Information Center, the medical toxicology fellowship director at Children's Hospital, and he's an associate professor in the School of Medicine at Wayne State University. He's an attending physician at several of the clinical facilities, including the Toland Park Opioid Treatment Program, Sinai Grace, Detroit Receiving, and Children's Hospital. He completed his undergrad training at Northwestern University and medical degree at WashU. He completed his residency in ER, as well as a fellowship in toxicology at the University of Pittsburgh. He has over 40 peer-reviewed publications, has had numerous media interviews, and has received funding at both the state and national level. He is the recipient of numerous awards, including the DMC Way Extra Mile Award in 2021, the Top Doc in Addiction Medicine Award from Our Magazine in 2021, and he's recognized as Crain's Business 2020 Health Hero. On a personal note, Dr. King has provided lectures to our PAS students during our yearly ER lecture series for our junior students and our opioid education training seminar for our seniors since he joined Wayne State. We all look forward to his lecture, and he's known as Scary Smart, his entertaining lecture style and approachability. Indeed, when some of his ER colleagues come and give lectures, they'll ask me if Andy has lectured before them, and they're always like, great. And he proceeds to warn our students usually that he is not as entertaining as Dr. King is. So his lecture today is Pain and Opioid Use Disorder, Evidence-Based Approaches, and we are very fortunate to have his expertise and experience in this critical and pressing matter. And please join me in giving him a welcoming award. So before we start, I just want to hand Dr. King his award and trophy for giving us this wonderful lecture today. So thank you very much, sir.
Should be good. All right, all set. Great. Any feedback? Can everyone hear me? Good morning. Thank you. Thank you very much for inviting me to be here. Thank you, Paul. Thank you, Kyle, Mary Jo, for that nice introduction. I really appreciate it. And we're going to get through like a lot of serious stuff today. And I want to let you know that some of the words that I might use, in case anyone has a history of substance use, might be a little bit triggering. We're not going to show any paraphernalia, et cetera, but we're going to talk about some very important matters, right? So this is not the usual entertaining lecture, but I think this is highly important, and we'll get to know why. My one disclosure is that I work as a technical assistant too for Community Foundations of Southeast Michigan, and we help set up what we call ED-MOUD programs. And so they're interventions that you could perform in emergency departments for patients with opioid use disorder. So they come in after an overdose or seeking treatment, and we can establish and train providers on how to use medications like buprenorphine and methadone, and then get them into outpatient care, which really is the life-saving intervention that we have, right? And so the objectives today, we're going to talk about the current opioid crisis in the Michigan and the US, define what OUD is, describe some of the evidence-based approaches for OUD, and then discuss the role of the pharmacist in pain management approaches and appropriate opioid prescribing and deprescribing. And so, this is the thing that Kyle showed me how to do. Let's see if I can do it. We have a question 1. The latest data indicates the following for Michigan. Do I do it now? Okay. Yeah. All right. Everyone can sign into this website and do the question here. So the latest data indicates the following for Michigan. I'm gonna read out loud so there's no dead time right now. Opioid overdose deaths decreased in Michigan. The rate of opioid overdose deaths continued to increase for all parts of Michigan, or the rate of opioid overdose death continues to increase for Detroit while remaining stable for other parts of Michigan. Just going to keep embedding people too. Is that okay?
Yeah. There's someone else in a different way. Yeah. Yeah, there's not much we can do. I don't know if you want to just speak through the desk mic instead, or you can stay here. Okay, cool. Let's try it.
All right. So let's talk about it. Here are the waves of the opioid crisis as we understand it. You want me to stay right here?
Yeah.
It's like with this thing. Okay. Now, I mean, this is something I've been around practicing medicine for quite a while. I'm not going to tell you exactly when I started, but we can see that this began rising in the 1990s, right? And there's a lot of literature behind it. I'm not going to go through all of the stories, but you can see over time there's been just a general increase in the deaths per 100,000 population. It hasn't stopped or leveled off at all. And you can see that, you know, the first wave really started with the increase in the amount of prescription opioids that were out there. And then there was starting to be about 2010, a rise in the heroin overdose deaths. And then more frequently, there's been an acceleration starting around 2013 with the adulteration or just straight up addition or substitution of the highly potent synthetic opioids like fentanyl, its derivatives, or we'll call them like fentanylogs or fentanoids, right? And so you start seeing what the death rates are doing, and they're accelerating. And like the most recent data we have in 2019 and probably 2020 now is that it continues to go up. And this is like an amazing number of deaths that occur every year. And it's not, we're not really bending the curve down yet per se. And then here's an age-adjusted one by jurisdiction here, and it continues to see what it looks like in Michigan overdose mortality. Specifically, the city of Detroit continues to go up, right? The medications for opioid use disorder, and we'll talk about the efficacy of those medications. And again, when I talk about those, the three medications that are FDA approved include methadone, buprenorphine products, and naltrexone for opioid use disorder, is that you can see that the medication for opioid use disorder, the prescription rate is half the rest of the state. So we have less of these medications just in general in the population, in the population that is continuing to have the acceleration increase in death, right? And when you look at this, this is a concentration of where the deaths are actually happening, or overdoses, at least per 100,000 residents. You can see that in 48201, where Detroit receiving is, or in 48235, where Sinai Grace is, those are relatively concentrated areas. And they're also like pulling from different areas too, right? So even though maybe Sinai Grace does not have like the same dark blue color as Detroit receiving or right next to it does, it doesn't mean that it doesn't catch a lot of those overdoses that are coming directly to the EDs there. And this is just like, you know, DMT specific data. And then the same thing again, when you look at Detroit, just shows you the same thing, just in different colors in a different way. When you break it down by Detroit residents continue to have and outpace the rest of the state in terms of opioid overdose death rates. And then of course, this is racial proportionally because, you know, most of Detroit is African-American, right? And so you continue to see the increased death rate there. Now, we already have an opioid epidemic. And then on top of that, for kicking someone when they're down, is that we added the coronavirus pandemic. And so, you know, you see, and we saw this in the lay press, and we continue to see this in scientific publications, the increasing amounts of opioid overdose in people struggling with substances that was compounded or started or exacerbated or just got out of control by the pandemic, right? And you can take a look at someone what this data looks like, is that you have, you know, kind of generally steady increase in overdose rates. But then when you have a stay-at-home order, people are bored and they're lonely and they got nothing else to do, and they don't worry, or they don't think about the future. And so one way to numb some of those feelings is to use drugs, right? And so what is the deal, right? Like, what is the cause? Why did that become such a problem? Well, when you look at the reasons that people return to use, it usually has to do, look at all these things: stress, negative emotions, social isolation, seeing or sensing the drug, just kind of around, like if it happens to be in the household, it's hard to escape that. Celebration, self-pity, dishonesty, unrealistic expectations. You can see how all of those things can be very much on the forefront of people's minds that are struggling at home by themselves in the pandemic. And I'm sure we've all felt a little bit blue because of this. Now, with the COVID mental health effects, right? Look at all of this. These are exactly the things. This is like a perfect recipe for return to use of a substance. Irritation, anger, denial, the uncertainty of the future, feeling helpless or powerless about what's going on around you, lacking motivation, like what does it all mean? There's been, a lot of question about like, what is the meaning of life? I think that has been on the forefront of a lot of our minds because we are here with the circumstances around us, right? Feeling sad or depressed, trouble sleeping, all of those things you can see lead to return to drug use or starting it. And so, this is just exacerbation. This is not, it's not epidemic times pandemic divided by mental health, right? It's just in general, like you can see how these things work with each other. And the numbers don't lie, right? We see that just a continuing increase and then a spike, right? So what's the problem just in general on a societal term, in societal terms about the cost of what OUD is? And then we know that we're spending $193 billion annually on not just healthcare, but treatment prevention programs, the traffic crashes, foster care, criminal justice, and that's just in Detroit, right? But across the country, $193 billion. I think that's a lot of money. So here's another question for the audience. The diagnosis of opioid use disorder relies on the DSM-5 criteria for OUD, the misuse of a legal prescription drug, or the patient not having an underlying condition that the opioid is treating, for example, pain. So let's see. There you go. Enter your responses, please. Again, that's the diagnosis of OUD is based on the DSM-5, the misuse of a legal prescription drug, or the patient not having an underlying condition that the opioid is treating. Yeah, the audience has it here. So what is the definition of addiction, right? I've been working in an opioid treatment program for the past couple of years. It's a methadone program, and we have patients come in. It is my favorite day of the week. It's one of my favorite things to do. And then I'll go into that a little bit, but I think that we conflate these terms, chemical dependence or dependence and addiction. They're two different things. Now, the definition of addiction that we have to think of as medical providers is that it's a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. And I've gone over this sentence over and over again in my clinical practice, and I can tell you each one of these things is very important when you're talking to a patient, right? Very much, it could be adverse childhood event. Very much, it could have to do with just the environment they grew up in. Very much, it could have to do with some underlying comorbid psychiatric disorder, et cetera, right? And very much, it could just be that you have a predilection for it. I don't tell my kids, don't do drugs because they're bad. I tell them, don't do drugs because you might like it. And you might like it a lot. And that's the problem with this one. And we can get into that in a little bit. But to continue with this, people with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. You can't not do it. It becomes just a reactive thing that I don't know why I'm even doing it. Sometimes you end up at work and you don't know how you got there. Does anyone experience that? Same deal. Ended up with some heroin right in front of me and I have no idea how that happened. You just kind of get there. It's like it's a quantum leap for people of a certain age. And then prevention efforts and treatment approaches for addiction are generally successful. That's important because a lot of times in I think the lay public and just general, like when I was being trained, is that there's a lot of therapeutic nihilism about how treatable these conditions are. But look at that statement, is that treatment approaches for addiction are generally as successful as those for other chronic diseases like heart failure and COPD and asthma, things that we take care of all the time. The difference between those chronic diseases and opioid use disorder is the stigma that's associated with them. All right. So this is what it is, right? It's the DSM-5 criteria. And I'm sorry for the small font, but it's important to make sure that we go through all these because this is the difference. This is making sure that we're not conflating dependence with addiction. The addiction component, the substance use disorder component, is all of these C's, like these consequences, the cravings, the compulsive use of it, and that causes problems, right? The consequences of use of the substance. So you're taking larger amounts for a longer period of time. You want to cut down or quit, but you can't. You spend more time using or recovering for the substance. You have cravings and urges, and they can be just, it's like screaming in the back of your mind, come on, let's go get some. If anyone has ever tried, I don't know, hopefully there's no vapors in there, but that might be, or nicotine or caffeine or whatever it might. You know, you can hear these like little whisperings sometimes, but can you imagine a screaming? And I'll show you some interesting papers in a second. Not managing to do what you should do at work, home, or school because of substance use. Continue to use even though when it causes problems in the relationship. And it can get a little bit deep, right? Like, are you fighting about money? Well, why are you fighting about money? Because all the money is going to dope or what have you. That could be a problem. Giving up important social, occupation, recreational activities, using it again and again, even when it puts you in danger. I got to stop right now because I got to tell you about some patients that I've had on consult service recently that are just, that continue to fascinate me and demonstrate, you know, how powerful this addiction disease is. And so a couple of the patients that we see, like they're young, 20-something-year-old females, right? And they have endocarditis and they have destroyed one of their valves. And so they have a big open heart surgery. And a couple of times, like we've walked in and described like what we're here for. And one person even just put their hand up and says, I know what you're here for. I know what you do. I'm terminal. She said that. It's like, I know I'm not going to be able to stop. Another one we had, like we were very aggressive about her care. And then as soon as she got decannulated and got off of all of the support stuff that she needed to have, she was there for a little bit. She was restless. And then she just took off. Like just a number of days, like right after having a big open heart surgery, being on life support. I don't know if this is like a bigger consequence. I can't think of any larger consequence than just having like a major surgery, but the disease of addiction was just so much. The cravings and the urges were just so much that they had to leave. And I'm sure there's other stuff going on, but that's just an idea of what it is, right? So there's those patients, but there's also patients exactly like that are in my clinic that have been doing well for a long time, that we see that have maintained, that had not had any use, that they have families, that they're contributing to society. You know, they have some pretty impressive credentials, and they had gone through this too. So, you know, we have to realize that these are not treatable diseases. So that's just one, again and again, even when it puts you in danger. So IV drug use or after an overdose, right? But you continue to go back to it. Continue to use it when you know you have a physical or psychological problem that could be caused or made worse by the substance. And then they have tolerance and withdrawal, which is really just dependence too. And so we have to remember that. But take a look at this, right? We all are made for survival. That is the point of a lot of the biological systems that we have, and especially in our brain, that we're made to be rewarded for doing things like eating and drinking and procreating, right? But look at what drugs do that are not natural things that have been put into our bodies, and look what they do to the percent of dopamine in those reward pathways that we have. Like when you're talking about getting a little bit of food, you know, increases maybe 150%. If that was an awesome meal, I should do that again. I like eating, I'm going to continue to do that, right? Like that makes sense. And it's not just the eating that's good, it's all of the, what gets reinforced is all of the behaviors that got me to that eating, right? So it's important to realize that like behavioral components are very important. The prefrontal cortex and the planning capabilities are very important that get reinforced. And then look at, you know, during sex, up to 250%. Now look at amphetamines, 1,000%. 1,000% of your typical dopamine in the reward pathways goes that much higher. And then cocaine, 350% of the basal release. Is that fair? Right? Would you lie, cheat, and steal to survive and eat and protect yourself and others? Kind of same thing with drugs. So contributors to addiction are big, right? It's multifactorial. And again, these are things that I talk about with the patients all of the time. And you can see how, you know, this is not like a one size fits all. Sometimes it is very much just genetics, like it just happened like this. Or sometimes it's very much like I'm trying to avoid a memory from an adverse childhood event that I had. but all of these things can go into it, right? And so you have to pay attention and be sensitive to those and be able to ask these questions to patients in like a very non-judgmental way, because they're used to being judged. And I'll tell you, patients can be very open with you when you are not judgmental and just asking them questions matter-of-factly. And so the biological factors, of course, genetics, developmental stages, sensitivity to drugs, mental illness, and gender. And then there's the cycle of addiction that we have too, which is preoccupation with it. So people just kind of wait for it. Like, it's very exciting. I'm about to go see a movie. Like, I'm really excited to do it. I'm going to go to, I don't know, Cedar Point or whatever. And it's going to be awesome. And then you binge, right? And that feels kind of good. But then there's the negative effect that happens, right? And then you start having decreased responsiveness to things that normally reward you. And then you have more increased sensitivity to stress. So something that normally had bothered you, like, really bothers you. And one way to fix that negative emotion is just to go back to use again, because that negative emotion will go away. And so that becomes rewarding in itself. So you can see how that just turns into a cycle thing. And then it turns into a spiral, right? Not just a cycle, but then a spiral, getting worse and worse and getting more and more out of control. And so that's why you're, not just reinforcing the positive aspects, but you're taking away the negative aspects too. A lot of times when people are kind of way into their drug use, and the people who are just tired of it, they just want to quit, like, they spend more of their time just not feeling good rather than normal. And they'll use just to feel normal and try to avoid like the hangover and feeling crappy all of the time, right? And so it doesn't become like I'm getting high anymore. It just is like, I just need to be able to function. So this is like the black hole of drug use, right? And some part of what we try to do by getting them on medications and getting them in treatment is to pull them out of this like really significant gravitational pull where all of their time and energy and thought is spent obtaining and using and coming down from substances, right? And this is pretty bad disease. So question 3. Treatment of OUD has been shown to A, reduce pain, increase tolerance, reduce criminal behavior, or increase the number of legal opioid prescriptions. Let's move on to the next one. There you go. Does it reduce pain, increase tolerance, reduce criminal behavior, increase the number of legal opioid prescriptions? Excellent. Okay, remember those responses. That's interesting. There's a couple of readings that I might suggest for you if you're interested at the end. Like, this one's a really interesting comic that's out there. You can find this, and it's called Rat Park, and it goes through the study of a group of researchers that studied rats. Right? We've all remembered, or you've seen the picture maybe in your head from a long time ago. Maybe if you're old enough to take the DARE program, is that there was the rat that was stuck in the cage that was hitting the bar so they can get whatever drug they wanted to, right? Now think about the environment that rat is in. It's in a wire cage by itself, hooked up to a paddle to give it drugs. If you were stuck in a wire cage by yourself, what would you do? Now, they took like these rats and they put them into like a rat park, like a rat paradise, where they could hang out with whatever rats they wanted to do. They had lots of stimulation, they had food, they could do whatever they wanted to with other rats. They had plenty of social outlets, right? And then they also put other drugs there, like it was morphine, I think, in this case. And they said, you can have morphine water or you can have regular water. And you started realizing that the rats they weren't really interested in the morphine as much when they had other things to do, when their environment was stimulating and they could have social outlets and be happy that way, right? And so you just wonder, like, why does our society, because of all the drug use and substance use, why does our society feel like a wire cage? And it's something for us to reflect on as human beings, right? But you're talking about now, how do we get someone out of that cycle with medicine? Really, the evidence for opioid agonist treatment is pretty impressive. Both methadone and buprenorphine have been shown to reduce criminal behavior, HIV seroconversion, opioid and other drug use, and then social dysfunction. So you're taking away, right, that preoccupation with whatever that drug might be, and you're replacing it with a safer drug that you can titrate, right? that can keep those cravings under control. So they're not spending a bunch of money on, heroin. I mostly work with the opioid use disorder, but, they can do that. And because they're not using, they're at less risk of an overdose. And because they're not using, they're decreasing the amount of times that they're sharing and using needles, right? And they're not seroconverting with HIV as much, et cetera. And they can actually function better. They can take care of their kids because they don't feel dysphoric and crappy all the time, that they're not having the ups and downs. They can feel level and normal for the first time. And so how do these medications work? There's 3 again that I wanted to show you that are FDA approved. We have methadone, buprenorphine, and naltrexone. And so methadone, for all the pharmacists out there, it's a low affinity, full opioid agonist. And then at the opioid treatment program that we have, we start around 30, 35. The maximum that you can do for the first day is about 40 milligrams. And then you do a titration up. Because of its long half-life, you only daily dose, and you can't increase the dose very quickly because that puts you at risk of dose stacking, right, and overdose and toxicity. So the first couple of weeks of initiating someone on methadone is really the most dangerous time, right? Because not only are you adding another opioid in there and you're increasing the dose as frequently as you can so that you can quench some of that craving, right? Like you can top that off, that they're probably still using some drugs on top of that. It's really hard to get rid of it. And so we continue to get to that point where they just don't feel like using anymore. So we're replacing the opioid there for them. So even if they do use, it's like, man, it's fine. This really wasn't the thing. So you start losing the positive reward as you get higher and higher, right? And then a lot of patients, then you find whatever that maintenance dose is. And the thing with the methadone dosing is that I like to tell patients, because they might have it in their head that, I don't want to go above 45 milligrams, or I don't want to go above 80 milligrams or what have you. But it's like a sleep number. That's all it is. It's like whatever your dose is going to be your dose. I don't know what your pharmacogenetics are. I don't know what your tolerance and dependence is going to be. Like whatever your dose is, that's your dose. Like we're going to get you to that point. So really, you are the barometer of how you're doing. Are you having cravings? Are you sleeping through the night? Are you having withdrawal symptoms? Does it hold you all 24 hours? Then we got the right dose. Are we avoiding toxicity? Then that's what we want to have. And so you maintain them as they start working on the other aspects of their life, right? Stabilize other things, work on relationships, work on the recovery process. And then they do better, right? When you start really withholding opioids from patients, right? And this is different from, a lot of what we're taught, because these are patients that already have substance use disorder, but like if you're withholding dose, you're trying to keep them at a low dose, they always kind of chronically just don't feel great. Like you're not quite there for them. And so like, what am I doing? I feel crappy all the time. I felt crappy before. I have to come to this stupid place every day. Like, what am I doing? What's the point of that? And so we have to get in our heads that it's a little counterintuitive or different than what we think about generally with medications is like the lowest effective dose. The effective dose for these guys is what it's going to be. So it really is a feedback, but again, you have to watch for toxicity with these, right? And so it's a little bit tricky. Methadone has a couple of things about it. Because it's a full opioid agonist, there really is no ceiling per se for respiratory depression. Some people have a little bit more of a resistance to that than others do. But you can overdose on methadone, and it can take a long time for it to clear the system because of its long half-life. It increases when you're doing other sedatives. So if you have benzos or alcohol or muscle relaxers, I hate that term, then it's going to cause a problem, right? It does interact with your potassium rectifying channel. And so it can potentially cause some QT. And that could be one of the things that limit our ability to go higher, or maybe we need to switch you. And then, it's only able to be regulated in specialty clinics in this country. In other countries, you can go to like your family doctor and you can do methadone treatment there. But here you have to go to a specialized designated opioid treatment program or methadone clinic, right? And because of the stigma associated with this, there's not a lot of methadone clinics around, or the ones that are there, right? It could be not in the greatest part, right? Do you want to have a methadone clinic in your backyard, in your community? Exactly. So that's methadone. Now, buprenorphine is a partial agonist. And so different than the full agonist, it's a partial agonist. The nice thing about buprenorphine is that this one is a high affinity partial agonist, but we're not going to do that one. Hold on a second. Let's go to naltrexone. So naltrexone is a high affinity antagonist. So I guess we'll do like top and bottom, then we'll go in between. It's a high affinity antagonist. And it's the oral and extended release injection formulations exist. The thing with naltrexone is usually takes a couple of months to start working, and you have to have a couple of things about you that are, amenable to naltrexone. So first of all, probably shouldn't have a chronic pain condition. So you're not going to be able to use any opioids for that. You got to be cool with coming in and getting an injection, like no aversion to needles per se. And then you got to show up, you got to get those injections. And then you have to go through complete withdrawal. So you cannot have any opioid dependence whatsoever before you start the naltrexone, because otherwise you're going to precipitate withdrawal and then that sucks, right? And I'm never going to take that again because that made me feel terrible. Then you probably, when people are on naltrexone too, they might have a bracelet or a necklace that tells them that they're on naltrexone in case they have some unexpected thing happen to them, right? Like a car accident, break a bone, and then they have a strong high affinity opioid antagonist on board. It's going to be really hard to treat their pain with opioids when they have an antagonist already there that you have to overcome. So you can, but it's difficult, right? But the idea is that they're on naltrexone, and if they try to use, it's just going to block it, so they're not even going to get any of that positive reward. And usually what we see, the effect happens, after a couple of months of the injection being there, and you have to show up and you have to continue to get the injection, right? And that could be a problem for some people. And this is one of the things that's been, preferred for people in jail or prison, and for sometimes inpatient detox. And so that one's out there. In terms of efficacy, there's a couple of studies out there comparing it to the full opioid agonist, but we'll talk about that later. But here's the idea is that when you start, and you can see that these are in treatment weeks, it takes multiple months really for the cravings to go away. Now buprenorphine. All right, we talked about full opioid antagonist, now buprenorphine. Now this one's the high affinity partial agonist with also a long half-life. And so you're generally just dosing this once per day. And it does have some analgesic properties like methadone. The analgesic properties are short-lived. And so if you are going to have someone come in for an acute pain control, then you really want to breaking up the methadone like multiple times per day, or same thing with buprenorphine. And then the nice thing about buprenorphine is that you really do have a ceiling effect on respiratory depression because of its partial agonist effect. So you can give them large amounts, in adults, large amounts of buprenorphine, and they're still breathing. The thing that kills us from opioid overdoses, right? That's the nice safety factor. And the other safety factor with buprenorphine is its high affinity. And so it's sitting on that receptor and it's avoiding other opioids, like it just kind of crowds them out a little bit, right? Like even if you tried to use something on top of it, it's really hard to displace the buprenorphine from that receptor. And so that's nice. Those are two really nice aspects about buprenorphine. So it limits cravings, treats withdrawal, outcompetes other opioids. And that's an important thing, right? So when we're talking about outcompeting other opioids, we're going to get into something called precipitated withdrawal in a second. But when we're talking about buprenorphine as a medication, you can look at the number needed to treat. And some of these are depressing. I guess it depends on how you think of this, but the number needed to treat for some antihypertensives to prevent heart attack, stroke, and death is 125 people need to be on this medication, or 67 or 100. But the number needed to treat with the average dose of buprenorphine to retain someone in treatment is 2. You don't see those kind of low numbers just about anywhere else in medicine or pharmacology, right? And the number to treat for preventing a death is 40. It's pretty amazing. Those are amazing numbers. And when you're talking about treatment, like this is, people say like, well, let's just get you through it. Let's detox you out. You don't need to be on that garbage all the time. You're going to hear this from people. They're going to be chirped at by their family members. Like just get it, detox. We don't want you to be on any chronic maintenance medication. Well, you tell it to someone with diabetes. We'll admit you for your DKA. We'll treat your DKA, but then you don't want to be taking that insulin the rest of your life, right? We're going to get you off that crap as best as possible. So don't worry about it. Don't say that to any other disease process. Why would we say this to this other chronic disease process? You don't need your blood pressure medications. We'll bring them down real quick. We'll give you some IV antihypertensive medications. Nothing wrong with that. And then we're going to wean you off of it. Like you could be on it for a short period of time, but I just don't really feel comfortable prescribing you insulin or antihypertensive medications. It makes me feel funky, so I'm not going to do it for you. Does that sound good? Great, awesome. I didn't want to be on them anyway. But when you talk about, just the general tapering, like people from, the amount of time it takes them to stay in treatment, right? If you taper them rapidly versus not, and look at the deaths, and it's just like small cohort of patients, right? 4 out of 20 of them died in the study period. That tells you something. And then you see the same thing over and over again. The evidence continues to point and push towards the same direction. So here's like a 10,000 foot study. this one's Baltimore, is when you started seeing like the increased amount of methadone clinics and buprenorphine patients. Like look at what the heroin overdoses did. So you can see the red line there is the general heroin overdoses that you saw in Baltimore over time. Remember, as nationally we saw a continued increase. 2009 was the from 1995 2009 was the duration of this study, and then you look at methadone increase and look at buprenorphine increase, and then you saw the inverse, right, relationship there. You saw declining death rates just in general, or overdoses. Now, same things happen in other countries, right? So the French field experience with buprenorphine here is that there was a big problem in the 1990s. I know we're talking about slightly different drugs right now, but there was a big problem. So they very much made buprenorphine very accessible. Like all the providers had to be trained in how to use it. And you can see like what happened with the heroin overdoses as the patients were getting buprenorphine. Look at that inverse relationship there over an entire country. And so look at the tens of thousands of patients that it took to get those kind of numbers. That's impressive, right? And over again, you see like when patients are on a medication for opioid use disorder, their hazard ratio is essentially like, indistinguishable from the general population. And then, oops, I pushed something. Sorry about that. Or if you have someone that is being detoxed, right, that can actually be harmful because you now have lost your tolerance. Like you've gone through this detox process, you lost your tolerance, and then you're going to go back, like you're going to be discharged from your 30-day program or what have you. You're going to go back into the same environment that leads you to use, right? You're going to be around the same people, the triggers, the stress. Like it could be really easy to be abstinent and drug-free when you're hanging out in a hotel room, right? Being positive, but then when you go back to the situation at home or the stress at work or what have you, then it can be much easier to get yourself in trouble. So a lot of what I've done in the past couple of years really is get emergency department on board that this is an emergency medical condition. And some of this comes from just straight up data that we have that after someone comes in after an opioid overdose, like their rate of dying in that next year is between 5 and probably 15%. We discharge those patients with nothing, or at least we have. Can you think of any other disease process where like you got like a 1 in 10 chance of dying this next year? Like, get out of here. Here's a clinic to follow up. Like, I'll let you do that. I have highly effective medications for you, but you can figure it out yourself, right? So that was embarrassing. Now, here's the deal: is that emergency clinicians, and I did this too, and this is I do have some guilt about my training. Is growing up, being trained is that how you're supposed to interact with people who use drugs. Are you supposed to stand at the end of the bed with your arms crossed like this, and you're supposed to wag your finger at them and say, "What's wrong with you? You only almost died. How stupid are you? What's wrong with you? You're fine now. Get out of here." That was it. That's embarrassing. We did that for decades. And so now we got to turn this around, right? We know that we can intervene, that the emergency department is an appropriate place to intervene. And we got to start working against these attitudes towards opioid use disorder, the effectiveness of it, and like what should we be doing when patients come in front of us, right? That have an extremely highly morbid condition. And so, you look at some of these discussions about like, what's the problem? Like the length of time for the wavering is burdensome. Well, it's actually gone now. Right now, if you want to get your waiver and prescribe buprenorphine, you literally just fill out a notice of intent. Done. You don't have to do this 8-hour training session. So some of the solutions were like, we'd make an education component. We actually pay people to get their butts in the seat so we can lecture them at how to use buprenorphine and like why it's effective and like turn and change some attitudes. So we did that before. What about, is it time consuming to engage patients for buprenorphine? Not really. You can establish a rapport. Like as an emergency clinician, you should be pretty quick to establish rapport with somebody, get their trust, and then have a discussion with them about like, what can we do here, right? And it can take just a little bit of training to get there, but that's more imagined and really not unique to anything else. Like you're establishing a rapport with just about any other person, like why not here? And then delayed clinical gratification, I think that's just like straight up wrong, because having someone be in withdrawal or having someone come in like seeking help, and then you can give them medication and almost immediately they feel better, almost immediately they feel like back to normal, like that's pretty gratifying. And then you get like a lot of unexpected hugs, which is the best part of my job. On a systems level, prescribing buprenorphine ED without the ability to ensure follow-up, like make a system, look around, see what other clinics are around there, and then just like partner with them. Say like, hey, our patients are going to be coming. Does that sound good? Like, awesome. And the thing is that there's a lot of people out there that are doing great work, and a lot of systems and a lot of programs that want these patients, but they just don't know how to connect with each other, or who am I supposed to talk about? Or even more interestingly is that they don't really even know. They didn't even think about that as a potential pipeline for patients, like to redirect them directly into care. What about financial barriers for continuing on buprenorphine after ED induction? It's always cheaper than heroin. If you look at a prescription for buprenorphine, it's probably maybe on the order, if you pay it out of pocket, 20, 30 bucks per week, 20, 30 bucks per day. But that's easy. Those economics work themselves out. And quite often, and because the pre-authorization has been removed, you don't have to worry about that part. But just in general, it's going to be like much cheaper for you to be on a medication. And then anticipated increase in ED volume for patients requesting treatment. We don't really see that. I think a lot of people had this idea that I was going to look like some zombie movie with a whole bunch of people like kind of coming in, like looking for a drug. That's not what we actually see. We're actually identifying people more often because they feel more comfortable, because they know that they've been offered or talked about it, in the ED, or they see signs up or people wearing a pin and say like, you have any problems with pills or heroin? Like, ask me about it. Like, oh, okay. I guess I'll ask you about it. It's okay. You wouldn't really see that. Or if you did, good. Like, aren't you supposed to be treating disease? Let me tell you, like, some of these patients are like pretty easy to take care of, at least acutely, right? And so when you're looking at the effectiveness of buprenorphine, like so we give them buprenorphine, like, are they actually going to follow up? Like, what's going to happen? And I think we've answered that question over and over again. I mean, these are pretty impressive numbers. If you compare, they've done RCTs on this. If you compare giving someone buprenorphine versus nothing, or just doing like a brief intervention, and there's a chance that they might follow up. But if you start them on a medication, there's a great chance that they're going to follow and they're going to want to continue. And all these various modalities are continuing to come out and show the same thing. Is like, you can have a phone conversation with someone, you can do a telehealth visit with them, like whatever it is, as long as you get them to feel better and normal, and then get them to a program afterwards, like there's a good chance that they'll stay engaged in therapy, for quite a while, right? And we know that when you're on these medications, we see the reduced mortality rate, and we see all of the other benefits with it. Like, that seems like a good thing to me. So when we're setting up these programs, like, we know, here's just the things that we know, and this makes a whole lot of sense. Let's use our left brain here. We know that drugs are poisoning and killing people. We know that survivors are at high risk of death in this emergency department, right? Like, after a non-fatal overdose, up to 10%, maybe more, are going to die within the next year. Like 10 of those patients, one of them you are not going to see next year because you failed to intervene. Survivors do not get adequate follow-up. Like, this is known too. Like, there's a very small chance that if you just let them try to figure it out themselves, they're going to have a hard time doing it. The ED potentially could be a teachable moment if you do it the right way. If you're shaming and yelling and finger wagging, it's not helpful. It can be counterproductive. But if you're doing it the right way and engaging them and bringing them with you on this journey, then it could be a very therapeutic thing. And I got to tell you, I have a lot of patients in my clinic that have actually had this exact intervention happen to them, and they end up in my clinic afterwards. And I asked them what that was like. It was like, it blew my mind. I had no idea that they cared about that. I had no idea. And that's pretty amazing. ED clinicians are willing to provide interventions, but we got to make it easy for them. If you're setting up programs, like, you have different audiences. You have the patients, and it should be pretty easy for the patient, but you have the providers, and they're doing something kind of new. And we know that doctors are really crappy at changing, is that you have to make it easy for them. And so if you minimize the amount of work that you have to do for them, just like a single phone number or what have you, set up a system that makes it easy, well, hell yeah, they want to do it. They want to do the right thing. You have to show them the evidence and that it's easy to do. And then patients linked to care have better outcomes, okay? So let's go to the next question here. Pain management in those with OUD should be A, treated acutely with non-opioid medications if possible, ignored because the OUD therapy will treat the pain, or treated only if the OUD therapy has been stopped. a chance to get some coffee. Why did you say December? Okay. We have majority there. All right, pain management. Don't rely on the medication for opioid use disorder, methadone, buprenorphine, what have you. Definitely not naltrexone to treat the pain. I think, it depends. That's their baseline now. You're talking about dependence, like that's their baseline. And if you have a new insult on top of that, then you can treat that new insult. You definitely want to maximize other therapies, right? All the non-opioid therapies, that's fine. But you can use full opioid agonists after you maximize everything else, absolutely. And you're going to realize that they have a higher tolerance, and so you have to use higher doses. And it's really interesting talking to some clinicians, especially surgeons, about what this means to them, right? What a pain seeker is, like what a drug seeker is. They're relief seekers. Or when you go buy a new car, right? Buy a new car. They're going to say this is the price, right? And what are you going to do? Like, absolutely. Absolutely. I'm going to pay whatever the sticker says. Can I give you more? Is that cool? Or are you going to come a little bit lower and try to meet somewhere in between? Can you imagine the same thing is for someone with opioid use disorder, that they come in the hospital, that they know that they're probably going to get stigmatized by somebody, maybe not the clinician, maybe. Or any of the support staff, they're going to be hearing some whisperings out in the hall about them. I got this addict and we're just a pain in the ass asking for pain all the time. So if you want the adequate relief, like, are you going to say, like, actually, can I just a Tylenol, like cut it in half and like in another half, and I'll just take a little bit of that. Actually, just leave it in the room and that should be fine for me. Or if you want adequate pain relief, are you going to maybe ask for a little bit more, right? So maybe you'll get something adequate. Like, what makes more sense to you? And when you bring it down to these kind of levels or these discussions with people, a lot of stuff that seems nonsensical and illogical starts to make a lot of sense, right? And you can see that this is just normal advocacy for oneself that it's hard to get mad at, right? They're not trying to pull the wool over your eyes. They already have substance use disorder too, because I've always heard this one. I can't give them morphine because they're an addict. What do you get from that? You get someone pissed off, and you get someone leaving the hospital AMA. Is that what you wanted? Because if that's what you wanted, you nailed it. But if you want them to engage in therapy and be there for you and not leave the hospital, then I'm saying, like, probably address it. You can use all the other stuff. They're incredibly willing to work with you as long as you're there to work with them about it. And you'd be surprised at how engaging they can be and how much discomfort they can tolerate if you let them know that I'm on your side. We're going to work with you. Let's see what we can do. We're going to experiment. It may be a bit of trial and error. That's cool, man. Or you take care, or you identify it. You start them on a medication, right? They might be a little bit irritable the first day. And then you see them the next day and they're like, yo, I am so sorry I was a dick yesterday. It's okay. I get it. Withdrawal, pain, right? You're stuck in a hospital bed. You also have to remember, like, where they're coming from. You're stuck in a hospital bed. You don't know what's going to happen. People are being mean to you. You're being interrupted all the time. You're incarcerated in a way, like you don't know when you're going to get discharged. That's a highly stressful environment just in general for patients, especially with substance use disorder. So anyway, like if they're on these medications, I recommend that you continue buprenorphine when possible. You can work with them, and it depends, like, if you consult us or not, we'll work with them about changing their dose of buprenorphine. You can decrease the dose and increase the full opioid agonist. You can increase the dose and increase the frequency. There's lots of different ways to do it, depending on what's going to go on. And the patient is whatever they want to do. Like, we'll help you out. You got to give them some agency in this too, because that's when they're going to engage in therapy and not take off, which again is counterproductive. And then you can get them into therapy afterwards. So this is like a spectrum disorder, like anything else. And it runs the spectrum from a mild substance use disorder to severe. Like the person who stopped me and said, I am terminal, that's severe, like right after you had open heart surgery. Or mild might be, I dabble, It's been a problem before, but you change, it's like diabetes, right? If you change your lifestyle, dietary modification, maybe you don't need medication. That's fine. And then there's everybody in between. So we have to remember that when we're taking a look at it. So it might just be easy stuff. So, well, maybe I just move out of my apartment, right? Or maybe I just need to do some therapy for a little bit. And then when you got the severe ones, like I'm not stopping no matter what, you got to ask yourself, like, what is our duty to those patients? Do they still deserve healthcare? Do they deserve like the best that we can do with where they're at? I think so. So that's harm reduction, right? So that's what we talk about. So I'm just going to tell you like what our journey has been at the DMC, just so you get an idea of what we've been doing around here. And this is just to describe like, you know, how you start implementing these things, which I find super fascinating and really fun and energizing. So you have patients that come to the hospital, and then you can you know, either send them to a program, and then they can figure out like what kind of level of care that they want to go to, right? Well, you know, but they got to get out of the hospital. They don't need to be here. They don't need to be in the emergency department. And so that you can have like an intervening place that can tell, I'm gonna go inpatient for this person, like maybe you're appropriate for a residential, or maybe you're even like sort of low risk-ish and you can do office-based treatment with like with your family practitioner. That's awesome. And so we've done that like in a couple of places. So like it was like a spoken hub model, is that we discharge them from the hospital to go to team or to FHLOC. And so they get some place to chill out, and they have a social worker, and they have like a doctor there and nurses, and they can figure out like what kind of level of care they need. Do they need to go inpatient? Do they need to go outpatient? And then they can continue my medication. And a lot of these places are really nice. Like you can hang out, get something to eat, like kind of hit the reset button for a little bit. They got some mild treatment areas, and so that's great. And so we set this up right from Detroit Receiving Hospital and Sinai Grace Hospital. So we were like setting these things up and sending patients there. So that's great. And then when we look at, and then in December, you know, harm reduction is really important. And you see naloxone being distributed all over the place, but it's really important. Like the high risk patients are right there in the hospital. Like you just overdosed, you probably should have naloxone. And you'd be surprised how often they don't have access to naloxone or never been given it before. And you can give them prescriptions, it's going to fill that. We know that you can give them a prescription for naloxone, but like I think it's less than 5%, probably less than 1% actually fill the prescription for naloxone. But when they're in the ED, you can give it to them and you can teach them how to use it. And when patients have naloxone, that gives them something that makes this whole experience real and a reminder. Like I just overdosed. That's a problem. They gave this to me. And you also I like to give it to them and say like, hey, here's now your ability to save someone's life. And it could be up to it could be amazingly powerful, is that up to 1 in 6 naloxone kits distributed saves 1 life to the high risk population, right? Reduces drug use. So the people who get naloxone are less likely to use drugs. And it's not one of those things that allows them to use more drugs or have increased high risk behavior, right? Oh, I'm wearing my seatbelt. I have naloxone here. I'll be fine. We don't see that actually happen. And then, and it doesn't prevent people from seeking treatment, but it actually, people that are involved in syringe exchange programs and get naloxone have a little bit of a higher rate of actually seeking that, right? So we started doing methadone clinic June 2020. We did the inpatient consult service. And so we started this just as a volunteer group of people. And then now our service is exploding and we're seeing a ton of consults and we're seeing a lot of patients that we can engage in therapy and get referred to and treated appropriately and not leave the hospital AMA because we're there, we're working with them. We've had patients say like, I was about to leave, and I would have left, but you guys helped me out and I appreciate that. We can reduce length of stay. We can reduce readmissions. So those are important things, right? If people leaving and get to AMA because you're not treating the substance use disorder, which might be the primary problem, then they're just going to come back. They're going to come back sicker. And then if you look at the 10,000 foot view, a lot of patients with substance use disorder will put off going to the hospital until they can't tolerate it anymore. And at that point, it could be harder to treat whatever disease process it is because they didn't want to get stigmatized while in the healthcare facilities, right? And then now we have syringe exchange programs with Wayne Health mobile units, and we go to a couple of places and we do that for harm reduction, right? And so again, the harm reduction method is helpful. It is beneficial. We see, we can reduce HIV prevalence, right? We're trying to decrease needle sharing. So if you're going to use, you can come and you can get a clean needle and you can decrease the prevalence of or the transmission rate. You know, hepatitis C. We can give you naloxone when you're there too, so you can take it home with you, so you can reduce overdose death, and then accidental needle sticks by law enforcement, so you have safe places for them to distribute their needles. You increase the proper disposal of syringes and other hazardous material. They have access to treatment. They have access to treatment, and they're 5 times more likely to access services and stay enrolled if they were part of a syringe exchange program. It's kind of what we're going for, right? Like, you let us know when you're ready. We're going to keep you safe. And when you're ready, you can always engage through us. So they're safe, effective, and cost saving. And then, of course, like, what they can always do, anytime the syringe exchange bus is out there, they always have access to me, and they can do like a telehealth visit, and we can have a discussion about like what's right for you and how do we want to do that. And we're happy to be there. It's like on afternoons, open, just walk in, right? And then now the thing that I'm extremely proud of is that we've made a nice partnership with one of the recovery programs in this area. And we have peer recovery coaches at Detroit Racine Hospital and Adult Central Campus. And so these are patients that have a lived experience with using, right? So they know what it's like. They can identify people who have used, and then they can talk about it with them, and they feel engaged. And so it's not someone with very different demographics talking to you, or someone who doesn't know what the heck they're talking about, but they can get in their face and they can have real conversations. And they perform these like screening and brief interventions or referral to treatment. And they've just been here since March, just March of this year. And this number, I got to update this. It's 565 since March, right? And they're getting into programs. So they're doing these interventions in the ED. They're finding people that we had no idea. And they're getting them actually into residential treatment programs, like from the ED, better than any of us ever could have, right? And so it's really important to have them there, kind of like lurking about, not in a creepy way, but it's like, I got you, man, let's talk. And they have all of these great, improvements too, because you can see what it looks like for someone to be successfully in treatment, like in recovery. And then they're spreading it out. So they're paying it forward, right? And they can be a mentor for anybody else that they find there in the ED, and then get them referred to programs afterwards, which again, is the sustaining life-sustaining treatment that we have. So what can you do? Like, this is the question. Like, what can you do? Well, you can do naloxone training. You can carry it around with you. You can have it in your glove compartment. You can have it in your bag, your purse, what have you. Stigma reduction training. I think the first part of the problem is like identifying that you have a problem. Like that I do have stigma. I do have like negative thoughts, and I did too. That this is not something that that you can accept about yourself. Like how can you decrease stigma, and like how can you improve the interactions of the people around you? MOED education and advocate for low barrier access, right? Some of the reasons that people don't enter treatment is because it's a pain in the butt. Like methadone programs could be a pain. Every day I gotta go. Every day. It depends on what they got going on. You got kids, a job. They're only open from like 7 to noon. Or if I go there, there's a whole bunch of people that are selling out in front of it. It could be difficult to find the right place for people to go to, right? But low barrier access clinics, right? If you start someone on medication, they're more likely to try it again later. And we see this every day clinically. It's like if someone's been on View before, they're like, yeah, I'll do it again. It was good. I had a problem. I don't remember what happened. Let's try it again. Did you learn how to ride a bike the first time? No. Did you learn how to walk the first time? No. It takes multiple attempts for you to get better and better at it until finally, right, you can get cruising altitude. And then you can support your local and hospital-wide efforts for establishing these programs and like understanding how all this stuff works. So that's it. I got a code here. I don't know what the CE code means. That's it. Okay. So thank you very much. I really appreciate being here. Thank you. Thank you. It's question time now. Anybody have any questions? In the back.
Thank you very much for an excellent presentation and overview. I have a question, and maybe it relates to one of your last slides about peer coach.
Sure.
What's the evidence, or what's your perspective on 12-step programs? This has mentioned them very much.
Yeah. So 12 steps can be great, right? It can help a lot with people's journeys, right? I think that having a scaffolding for how people can think about, how they've gone about their life and how they want to make a change, locus of control, et cetera. That's actually like a whole nother discussion. The 12 steps programs can be very helpful for certain people. What I'm really trying to emphasize here is that the best evidence is, medications. Abstinence. A lot of the 12-step programs generally are for alcohol, and a lot of 12-step programs are not super medication friendly per se. And when you're taking and that might be great for some people, right? For the general population, when you're talking about, the large view, we really need to focus on the highest effective interventions. 12 steps, again, can be very helpful, but I want to make sure that we do things and advocate for things that work, that we know that work the best. And again, for opioids specifically, that's kind of where I was focusing on this talk. For alcohol can be a bit trickier because the medications may not have the same effect size that we like to see, but still possible, still treatable, and something that we should definitely focus on. Cindy.
Thank you for this. One of the things we're seeing is that people are using more than opioids. They're also using stimulants. So is there anything that you do different because of the stimulants?
No, that's a good question. So it's the epidemiologist over there asking the question. So we're having a big increase in stimulants across the country. Everybody know meth is becoming a big deal, right? Like cocaine is there. Now there's not great effective treatments for these, and nor are there really any FDA approved programs, medications that are there for that. I think some of the best evidence is for contingency management programs is you give me a negative drug screen, you can have $1. You're yeah, that actually works pretty well for some people. But the best thing you could do is control what you can control, right? And you get that from kind of 12 steps ideas. If I can control opioid use, a lot of times other drugs follow. You'll see reduced use of other things, right? And if you put them in a program like an opioid treatment program and they have cocaine, then cocaine becomes less and less frequent, once you get the heroin under control. And so I think one of the things that you can, that is important is making sure that you're treating what you can, and then you have them engaged in therapy so you can work on those other ones, right? It's and then depending on what the deal is, right? Are they stimulants because, well, there's a lot of things, I'm not going to get into it, but control, right? And then a lot of drugs follow.
What would you say to pharmacists who are overly concerned about diversions in the community pharmacies of buprenorphine to the point where they're telling people, oh, we just don't have the drug, and viewing operating script as suspects? What do you think about that?
I love that question. Thank you for bringing that one up. That is a big deal, and I've spent a lot of time on phones for patients trying to find a pharmacy that is actually distributing buprenorphine, right? And I want them to turn around and take a look at their stock. It's you have plenty of oxycodone. Oh, you have hydromorphone. Oh, how about fentanyl patches? I got it up to wazoo. You have any buprenorphine? Why is that? Why is that? I think it's stigma. I think you don't want those people coming into your pharmacy. I don't think that I mean, that's kind of where we started, right? If you go back to prohibition, look at what happened, right? We had alcohol, and then we took it away, and then what filled in there, right? Drug cartels, and then highly potent stuff, white lightning, gin, right? It wasn't light beer. It was highly potent stuff. We have a problem again here is that, we are decreasing the amount of opioids that are out there, and then who's filling in for the reduction that we got going on, right? So we have a whole lot of people that need some help. We need to be able to make it accessible for them to have buprenorphine. And so what I would say is that I think ask yourself in a very deep way, when you are comfortable, is why am I not offering this medication? Why don't I have it in my pharmacy? And I'm going to guess it has something to do with stigmatization, right? And in terms of misuse of buprenorphine, let me put it this way. if you're going to misuse an opioid, which one would you want to overdose on? Like one that's going to be stable from a respiratory standpoint, or one that could potentially kill you?
So the comment about the use and going back to the French study demonstrated the decrease in heroin use, the increase in accessibility to methadone, propionate, brings up the idea of provider status. Additionally, these are things that MDs have been developed to give to PharmDs in order to prescribe in them. So what is your opinion on the ability to have PharmDs and other healthcare providers prescribe to increase access, as opposed to regionalizing it to clinics and under the auspices of only an MD?
I'm trying to strike a balance here. I think that's a great question, right? Trying to strike a balance between accessibility, because we don't want people just willy-nilly able to, pick it up. Like if it's just like a open candy, Halloween candy that people just grab buprenorphine whenever they want to, right? Like we want to minimize people's first exposure to opioids because that's going to put them at risk for it. But I also want to have decrease and increase accessibility to life-saving medications, right? And I think in this case, I have no problem with pharmacists, being able to prescribe this medication, right, for the right population and under the right circumstances. And I think that when we see this kind of thing, we need to change the culture that makes it accessible and easy for people to access medications and get better. Right. And whatever that takes. And again, I don't want to speak out of turn and get myself in trouble because I assume I'm going to be recorded here. I'm never going to be able to run for president if I say the right thing. But I mean, that's the idea. It's like, I have no problem with that. And I think that would be great. Yeah, there's a lot to unpack with that question. When people are put on chronic opioids, right, you develop dependence. And that means that if you just stop it, you have withdrawal. And then it can blur the lines a little bit, is that dependence can turn into more of a substance use disorder, right? Some people can just be on their chronic opioids and be totally fine, meet no criteria for opioid use disorder, never have a problem. And some people, it does kind of get a little bit funky, and then they may run out of their prescription opioid because their tolerance and dependence changes, right? And then they move to something harder, and then it becomes more of a problem. Buprenorphine, yes, does have formulations that are used for pain. So like the Butrans patch, for example, is a medication that could be used for pain control. And so it depends on the formulation, and it depends on how the FDA, marked it, right? So if it's buprenorphine for substance use disorder, if it's buprenorphine for pain control, and you don't want to mix and match. You can also prescribe methadone for pain control. It's dangerous, and so a lot of the studies and a lot of the problems we'd seen methadone before is that the death rates that was associated with methadone was because it was being used for pain control because of its long half-life and other problems with it. If you have a whole bunch of methadone out there that people can just take however they want to rather than like metered daily dosing, that could be more of a problem. But yes, methadone could be used for pain control, but you can't prescribe methadone for substance use disorder, for OUD. So those are the problems. And then in terms of if people develop, you're saying like if people develop a substance use disorder with methadone or buprenorphine, yeah, that happens. It does happen. And then they should just be referred to us, right? So it's going to be a discussion. Like some patients, right? And again, this goes to, and I don't want to be too confusing, but like if some patients, if their first exposure to an opioid is buprenorphine, that's tough. And we actually had a patient with endocarditis, like she first got exposed to buprenorphine, like she found those somehow. If it wasn't that, I'm sure it was going to be something else, right? And that's the problem with a lot of substance use, is that if it's not that thing, it's going to be something else. And then she went to methadone, she went to IV heroin, endocarditis, et cetera, right? We're switching her to methadone, and so she can do it at a highly regulated clinic, so it can be done in a safe way, right? With like high structure, because she's got pretty severe disease. Did I answer your question? I kind of went off on a tangent. I got it. And then vice versa, right? It depends on what they need. So it's really patient dependent. I can't give you the exact answer there. Into the weeds with the question. All right, thanks again, everybody. I appreciate it.
Yeah, you can serve. So for any pharmacists, the code's up here. You need it for your CE, so copy that down. For those who want to stay for the award announcements, we're going to do those now to. Yeah, that's fine. So we're going to do those now so that we can move on and get out of here for the next class. So in the postdoc category, the winners are Hari Prasad Aruri and Dinashnina Chauhan. And we have if you happen to be here, you can pick up your certificate. Yep. The winners are Hari Prasad Aruri and Dinashnina Chauhan. In the health science category, the winners are Kayla Durbin, Abdallah Mrech, and Taylor Takla. In the pharmaceutical sciences category, the winners are Morgan Manjares, Chris Armstrong, and Jeremy Kelm. And finally, for our undergraduate category, the winners are Zaid Abu Ras, Alyssa Kimbrough, and Miriam Abawi. For anybody whose name I call, you can come up and pick up your certificate. Otherwise, I want to thank you all for making College Research Day successful. Thank you to the Dean. Thank you to the College Research Committee, Karen Tarnas, Michelle Strund. Thank you so much, everybody.